I've never met anyone quite like the Indonesian Minister Budi Gunadi Sadikin. First, he doesn't have the typical resume for a health minister. In fact, he has no health background at all. But he does have something else on his resume that has proved to be quite useful.
I used to run the largest bank in the country as the CEO.
After COVID started, the president of Indonesia approached him to lead the health ministry.
Maybe the president think this guy can do difficult jobs. So COVID-19, you need to vaccinate 280 million people across 7,000 islands as fast as possible. Why don't I bring this guy in? No considerations about the background whatsoever.
He took over the job on December the 23rd, 2020. And 2 presidents later, he's still there.
For the first 18 months in my jobs, I behaved like Minister of COVID, Ministry of Vaccination, not the Minister of Health, because I just want to contain the pandemic, do 400 million jabs to 200 million people as quickly as possible.
In this early period, he came to understand something important.
I realized many institutions is eager to give us money. As long as you can be seen by them, you can execute, you don't steal the money, and you want to really save life passionately. So I get a lot of support from Gavi, from Global Fund. It's billions of US dollars also. So money is not an issue.
So how did you convince these stakeholders that your vision was one they could align with?
You have to understand who to contact.
Budi has raised a lot of money from the World Bank, Gavi, and the Global Fund, to name a few. And he's helped build a new vision for health in Indonesia. But how did he do it? And what can his experience teach us about how to shift away from aid towards economic growth? I'm Henry Bonsu, and you're listening to The Threshold, a podcast from Foreign Policy about how to end the deadliest infectious diseases around the world. On today's show, we're tackling what is possibly the biggest challenge facing global health right now: funding, or a lack of it. We all know that foreign aid is shrinking. Already, the consequences have been devastating.
Credible estimates indicate that this is already costing more than 300,000 lives, most of them children.
For leaders around the world, the crisis is daunting, but it might be something else as well. An opening for something new, a chance to build something better.
Out of adversity comes opportunity. Africa must no longer be the patient. It must be the driver. It must be the author.
President of Ghana, John Dramani Mahama, brought African government officials and global health partners to Accra this past August for the first ever Africa Health Sovereignty Summit.
Let us reset the moral compass of global health. Let us build systems that generate wealth, uphold dignity, and expand purpose. And let us not only reimagine our future, let us own it. And let us make our systems more resilient and self-reliant.
We'll hear more about that summit later in the show. But first, let's get back to my conversation with the Indonesian Minister of Health, Budi Gunadi Sadikin. We met in New York when Budi was in town for the UN General Assembly. He explained that with COVID, his immediate problem wasn't money, it was access to vaccines.
So what I did is try to look for the best provider or channels that can provide me those access. I give you one example: vaccine. Indonesia cannot access any vaccine because the Pfizer, the Moderna, they are not thinking that Indonesia can pay. And Indonesia is middle income country, so they will go to United States, Singapore, and other rich countries first. That's why I have to go to China. So I got the first batch of vaccine in China. So when we start vaccinate the people, one of the fastest in ASEAN at that time, very similar or faster than Singapore, then other companies start thinking, hey, this guy is serious.
Indonesia could distribute the COVID vaccines faster than many other Asian countries, and Gavi started getting donations from Pfizer, which needed to distribute the COVID vaccines quickly.
And then after Pfizer coming in, Gavi, the institution that distribute free vaccine, have a lot of pool of vaccine, and they are looking for somebody that can implement. Because many countries like United States bought 3 times the population or 3 times needed, but they forget that there is an expiry date. So rather than have the vaccine expired in their country, they give it to Gavi, but it's very short, expiry date, only 2 months, 3 months. So Gavi give it to the African, which is normal. At that time, I can deliver 2 million jabs a day. So when Gavi CEO said, Budi, I have 10 million vaccine, but the expiry date is a month, or just send it to me. Why? I can finish that in 1 week. So he's happy. And then I started receiving wonderful, great, expensive vaccine from Gavi. I think the value is 1 billion.
Budi had something a lot of countries didn't: a strong health infrastructure that could deliver vaccines quickly and at scale. After COVID rates dropped, he turned his attention to another problem in his country: the infant death rates.
I realized that children mortality in Indonesia is extremely high. Babies' mortality below 1 year is 30,000 every year.
He got Gavi to help Indonesia launch 2 vaccines that were crucial to reducing child mortality: the vaccine for pneumonia, called PCV, and the vaccine for diarrhea, or rotavirus. But the death rate is affected by other things as well. At some point, he realized a shortage of ultrasound machines in Indonesia was a factor. Sadikin says that in the 10,000 primary healthcare clinics in his country, there were only 2,200 ultrasounds.
If you are a pregnant mother in Indonesia, you deliver your baby and you receive 1 single ultrasound to check the condition of the baby, you are the top elite 32% of Indonesian pregnant mothers. The rest, they never been ultrasound. So what I did, I bought 8,000 ultrasound and delivered in 1.5 years.
He explains that the country's national health insurance system, which passed in 2014, is a major achievement, but it doesn't necessarily translate to better health.
The problem that we have, you go to the hospital, we cannot treat stroke, we cannot treat cancer because we don't have the instruments. Again, the problem is with money. So this is where my background as a banker helps.
Okay, so up until now, you've heard Budi talk about the challenges and what he really needs to solve public health problems. From here, he gets into how to raise money for health.
To ask money from my Minister of Finance, I will complete this project maybe in 10 years because annual budget is limited. As a banker, I know if you want to bring tomorrow's now or bring the future now, you go to any banks. The biggest bank in the world is called World Bank. And the World Bank CEO is my friend because he used to be a banker. So I call him, can I borrow money from you? How much, Budi? 4 billion. Typical banker. What for? Oh, can I come and present to you? This is my plan. 10,000 primary healthcare clinics. I want to do this. 540 hospital, cath lab, CT scan, safe from stroke and heart disease. This is a plan. And if you run the procurement system, because that will help me. Developing country, corruption is everywhere. Why don't you, World Bank, run the procurement for me? Negotiated the price with Philips, GE, and Siemens, and I can get a good price because of your procurement skill. He said, give me 3 months, and he approved the loan, 4 billion US. My budget, annual budget now is 4 billion. I signed the agreement in 2023. Negotiations is only 6 months. I doubled my budget, and bring all the 10 years into 2 or 3 years.
What would you advise other ministers, perhaps in Africa, who are ministers of health or indeed ministers of finance, who don't have the same connections that you might have? What would you advise them to do?
First, as a banker, I know the world has a lot of money. Now, some of the sector, some of the country needs that money. They just have to understand how to get the money. And we have also to understand that we cannot live forever from grant. We have to have a very clear financial roadmap. Yes, Indonesia in the last 10 years we live 100% from grant. Now 100% grant, 50% grant, 50% our own money. Then maybe 50% my own money, 25% borrowing, concession loan, low interest rate, 35% grant. And then gradually we have to graduate from the country that always receiving money from grant, as we are the children that don't want to depend on our mom and pop, to get more money. So that is the first advice I gave to my fellow health minister. And second one, bankers have tons of money. They just need a credible plan. And my offer, and I did this already, I'm willing to share my knowledge. I used to be a banker that approved the loan. I know that their expectations about, before I give you money, I want to see this.
And Budi, Indonesia has made such great strides that after years of being a recipient of the largesse of the Global Fund, you are now a donor, which is extraordinary. And you took money from your national state budget in 2022 to support the Global Fund. How was that move received?
Global Fund has given Indonesia more than 1 billion US. I think the exact amount is between 1.2 to 1.4 billion US since 2003. And the current CEO of Global Fund, Peter San, used to be the CEO of Standard Chartered Banks, my competitor in Asia, because I run the largest bank in Indonesia. So during pandemic, we had a G20 meeting in Italy, and he saw me. I think I know you. Yes, we know each other, Peter. Oh, we are very happy because two finance guys, working on health. And he said, Budi, I've a lot of money that I want to contribute for vaccine. And you are trusted, you are a banker. I will give you money. And I said to Peter, I'm a banker. So I believe on leverage. Example, if you want to buy a house, a mortgage of car loan, the bank always asks, you have to put 30% or 20% down payment just to secure that you have some equity involvement in it. So I said to Peter, three times leverage is something normal in banking. You put 30% and the bank will give you money 100%. So Peter, you give me a lot of money, I give you zero. So why don't you help me convince my Ministry of Finance? I will contribute also to Global Fund, but of course you give me more. Yes. Multiplication. Right. and that is my justification, Minister of Finance. Come on. He gave us every 3 years 300 million. So if we contribute 10 million and get 300 million, that is 30 times leverage. 3,000% leverage. Is that good? And we also show the other countries that, hey, you cannot live forever just receiving grant. This is time, although small, you contribute. And that will be seen as other country. Hey, Indonesia, middle income country, contribute. Why Netherlands used to be in Indonesia for 350 years, only contribute the same thing? They don't feel embarrassed. So I help Peter San also.
And how crucial has that money that the Global Fund has been giving Indonesia since 2003 in the fight against infectious diseases, particularly tuberculosis, which kills 100,000 Indonesians every year?
For Indonesia and many other countries, tuberculosis is the number one killer out of these three. This is the most deadly infectious disease, even more than COVID. And I don't understand why, after 1 billion deaths in the last 200 years, we haven't been able to take care of this tuberculosis. The problem is tuberculosis is a low-income country disease. So there is no enough allocation of money. Global Fund is very nice in giving contributions, and also the Gates Foundations to support tuberculosis elimination in this country. Any infectious disease, the first most important strategy is to detect the person. Because otherwise, if we cannot detect the person properly, this person will spread, the disease everywhere. So we need to detect the person and then give them the treatment. And the treatment in tuberculosis is very effective. And the last one is to develop vaccine. Now I sit as a co-chair of Global WHO Vaccine Accelerator with the Ministry of Health of Brazil, and our plan, with the help of Gates Foundation, hopefully we can launch the tuberculosis vaccines in 2029.
Tremendous. And Indonesia has an ambitious plan to eliminate tuberculosis by 2030. Yeah. We're coming towards the end of 2025, soon 2026. Are you on track?
My experience with COVID and any infectious diseases, whatever you do, whether you have the medicine, therapeutic, screening, surveillance, only vaccine can eliminate the diseases. Like example, polio is close to elimination, smallpox is eliminated already. So I strongly believe vaccine is a game changer. And we have seen it in COVID. COVID is going down because of the vaccine. So that is the reason I'm pushing the vaccine. I sit at the board of Stop TB Partnerships. We had a meeting in Brazil, 2024, I remember. And then my first board meeting, and they said, the vaccine will not be ready until 2032. I'm already appointed by WHO as the co-chair of Global Vaccine Accelerator. The problem with this tuberculosis person, they are not as aggressive as HIV. So the HIV group of people globally understand, if we don't get this treatment, we will die. So they will fight for anything. Even in the United States, the HIV group is very militant because they want to live. This tuberculosis is very weak, so you have to push them a little bit. So I said, okay, I will push them. So I said to them, hey, our WHO target is 2030. We want to eliminate. We know if we want to eliminate tuberculosis, we need to have vaccine. But if all of you put the target to launch a vaccine in 2032, why don't we pack our bag and go to the beach rather than have this meeting? So let's make it 2028. Roughly, I believe 2029 will be available, hopefully. And I see the progress in the clinical trial is good. COVID-19, you had the vaccine, the Pfizer, the Moderna. 1 year is enough. We deploy, we launch, we close the COVID-19 chapter.
It's a very exciting development, and part of the strategy is that phase 3 clinical trial for this promising TB vaccine supported by Gates. And if it's developed and it's successful, it'll be the first in a century. But there's vaccine skepticism all over the world, including in this country, the United States, where we're speaking, but also in middle-income countries and lower-income countries. How much of that have you encountered, and how have you combated it?
I feel very sad because with this social media, the anti-vax is getting stronger. My first experience with anti-vax movement is during COVID, because Indonesia is Muslim country. So Muslims are very sensitive about halal issue. Whether the vaccine is developed using an ingredients which cannot be accepted by Muslim populations. So AstraZeneca at that time is the second vaccine that we contracted after the Chinese one. And this is the first Western developed vaccine, which is good enough. For me, it's good enough. The problem is there is an issue with this halal. And if I cannot solve this issue, then the vaccination will be a failure. So what I did, I came to see the most influential clerics, Indonesian clerics in East Java. East Java is the center of the Indonesian clerics. I came to the most senior. I explained to him, I just want to do to save life. Isn't it in every religion, we are here to save other people's life? Finally, he agrees, and he said, Budi, give the injections to me first. So with WHO, from Gavi, everybody, we come to that event, have a lot of media, and we vaccinate this 70 years plus old clerics in East Java. So everybody see, hey, even my greatest teacher is being vaccinated. So all, the students, 100,000 of them are following the teachers. That is very typical Indonesian. So with that cleric demonstrations, when he was vaccinated, 90% of my problem got solved, because people that now trust, hey, even the senior clerics of Indonesia is showing example that is okay.
Towards the end of our conversation, Budi had this to say.
The best people is the people that do good things for others. Bankers for 30 years, largest bank in the country, I have enough money. I have enough what I call earthly investment. I will never running out of money until I die. But when I die, as a religious person, as Muslim, I realize I cannot bring that money there. I cannot bring the interest, I cannot bring my property, but what I bring is the good thing that I have done to other people. So I need that heavenly investment now. I need the heavenly deposit, rather than the earthly deposit.
That was perfect. You've landed beautifully. Budi Gunadi Sadikin, Minister of Health for Indonesia, thank you very much indeed for being my guest on this podcast.
Thank you.
So, what are some of the smart things that Budi did? He identified the key challenges he needed money for, whether that was vaccines or ultrasounds or diagnostics. And Indonesia had built a strong enough health infrastructure that he could deliver these tools at scale. Plus, he used leverage from outside donors like the Global Fund to raise more of Indonesia's own financing towards these projects. After the break, we'll speak to Dr. Ngozi Erondu from GLIDE, the Global Institute for Disease Elimination. She was among a small number of people invited to attend the Africa Health Sovereignty Summit, and she's optimistic about its potential. More on that in a moment. Earlier in the episode, I mentioned the first ever Africa Health Sovereignty Summit in Accra. It's generating a lot of buzz. African leaders and global health partners met in August to redefine Africa's role in its own health future, including shifting from external donors towards self-reliance. And they also launched an initiative at the UN General Assembly called the Accra Reset, hoping to reclaim not only health, but also other development goals.
There are 4 important areas of health: education, food and nutrition security, and climate change. These 4 areas are interconnected and we cannot treat them in silos.
It's not the first time something like this has happened. There was the Abuja Declaration nearly 25 years ago, which called for African governments to allocate at least 15% of their national budgets to improve healthcare. South Africa and Zimbabwe were among the first countries to do this. And as of 2024, Rwanda, Botswana and Cabo Verde have also met the 15% target. So what is different this time around, beyond the foreign aid crisis? I spoke with Dr. Ngozi Erondu at Foreign Policy's UN General Assembly headquarters in Rockefeller Plaza. She's currently the Technical Director of GLIDE, the Global Institute for Disease Elimination, which has been in the global health world for a long time, and it wasn't my first time meeting her.
You ever been to a Formula One centre in Woking?
Yes!
Yes, and you were sitting on a panel.
You are so good.
With the former BBC World Health
It was about
correspondent.
malaria.
Yes.
At McLaren?
Yes, at McLaren.
Yes.
And I was the moderator.
You were.
Yes,
oh
you
my
see?
God.
She started our conversation by painting a picture of what it was like to be at the Africa Health Sovereignty Summit.
The Ghanaian president, President Mahama, really saw this opportunity to transition from rhetoric to reality when it comes to African health sovereignty. And he wasn't the first person to do so, but I will say for me, it was the first time to see a president, like at the presidential level, really bring all the different players to the same place. So, and it wasn't just stuck in health, because that's what we saw at COVID-19 is like, health ministers talk to health ministers. We talk to WHO, we talk to Global Fund, but nobody talks to the rest of the world. But the rest of the world is who's at risk when there's a pandemic, right? And so then you get, economic ministers, making decisions, which they have the right to, but they might not be health informed. You get military involved, you get airline, everything is affected. So during peacetime, how can we really have health in all policies? How can Africa really make a plan to move forward when it comes to domestic resource mobilization, when it comes to public-private partnerships, when it comes to being able to provide essential health care to everyone in their country, like really strengthening primary health care. So that was the reason why President Mahama brought everyone together. And to me, it was very inspiring because it wasn't just President Mahama. It was former President of Nigeria, President Obasanjo. It was former President of Liberia, Ellen Johnson Sirleaf. What has come out of COVID, if you ask me, one of the most positive things for global health is this regional strengthening, right? It's Africa CDC, it's the Africa Union, it's the African Medicines Agency. It's this coming together that says we are better together, we're stronger together. And how do we coordinate and harmonize and push the initiatives for our continent forward? How do we make sure that regional priorities that reflect national priorities are what we're funding and what we're driving? I mean, I remember when I started Global Health, I used to work a lot on polio eradication. And one of the talks that I've done on YouTube, I talk a lot about like walking past people that had something that you would think as benign as chickenpox. So people die from chickenpox, right? But I was funded to look for polio. So I'm going to walk past the chickenpox. I'm going to walk past the malaria. I'm going to walk past a lot of things to find that polio case. And I'm not trying to drag polio. I think it would be fantastic if we could actually eradicate polio, and we're so close. But who said that polio should be what we focus on? Was it the Kenyan government that I was working for? Because at that time, they had other issues. They had a lot of other issues. So that's really, when we're talking about reimagining global health, and we're talking about reimagining governance, we're talking about reflecting the proximate issues, not just the global ones.
But it's one thing to talk about country ownership and saying, look, okay, we should be focusing on polio, but if Gates or the Global Fund tells us we should be focusing on something else and that's what we're going to fund you for, then that's what we have to do. If countries are not achieving the 15% spend of GDP that previous principles and accords say they should, and I think out of the 47 African members of the WHO Africa region, only about 3 are, how on earth are they going to achieve this African health sovereignty?
Now you're heating up. No, it's important. I mean, during the summit, there was a lot of conversation about like true ownership is putting your money where your mouth is. It's not just telling other people what to do with their money. And so the summit really leaned into domestic resource mobilization. It leaned into African countries and institutions being able to pay for at least the very basic health service, the primary health care. How do we really center primary health care? And, you hear a lot about universal health coverage. We can't get to universal health coverage if we don't have strong primary health care. If you cannot go to a clinic and not have to pay out of pocket for the most basic health care. Like, we will never have universal health care. So a lot of that focus was on there. How do we fund that? One thing that Ghana put forward, in addition to, driving sovereignty and governance in those discussions, was something called a sustain framework. And just to make it really simple, what the sustain framework is looking at is understanding all of the inputs to health, whether it be from external sources or internal sources, and calculating how much that is. Then looking for redundancies and inefficiencies, similar to what actually the America First strategy that was just released by the U.S. government has proposed to do. But looking at inefficiencies, saying like, we're spending $1 billion here, we probably could spend $500 million instead. Then actually knowing exactly what it costs to fully fund primary health care or basic health services in that country, and then looking at the gap. So the sustain framework is really an example example of, how countries can actually know how much it costs, see what funds they have to fund their health system, and then invite global health partners and academic institutions or whoever the external partner is to kind of fill the gap. And I think if you do it that way, then you can be more directive. There are several African countries that say, look, this is what our priorities are. If you want to work with us, this is what you'll support. There are a lot of Asian countries that have done that as well. Indonesia is a very good example. These are our priorities. If you want to partner with us, then you will support that.
Here in the US, they talk about America first, but there are echoes of this all around the high-income countries where there is pressure from taxpayers on governments to look after charity at home. It's a tough time in global health. There are serious headwinds, but there might be opportunities. What do you hope emerges from this crisis, particularly when it comes to African countries stepping up and doing for themselves?
I think our kind of knee-jerk reaction is to say, like, cuts to global health, this is bad, But there are a lot of things within this strategy that I think reflect the uneasiness that we've had in global health for a very long time, like dependency, the lack of sunset clauses for some of these institutions, including Gavi, including the Global Fund. Are they supposed to just go forever? Is there never supposed to be any type of transition to the country health system and country ownership? So I think it addresses a lot of those things there. It really does kind of limit to HIV, malaria, TB, polio. So I think it's not as expansive as we would want as far as which diseases it covers. But in some ways, that's also reflective of another point of uneasiness, which is these vertical diseases. Like, when we go to a hospital, we're not like a malaria person. We're a person who has malaria. And we could also have TB, actually. And we could also be pregnant. So, a health system is supposed to help a person, not a disease. And within these strategies, I see a lot more about efficiency and integration. And I think these are really good problems for the global health community to solve, right? Like, how can our systems be more integrated? How can our health information systems look at integrated disease surveillance? So I think we need to look at this as an opportunity, even though it's very difficult to deal with the sharpness of the cuts, right? Like, it's not people like me thought that aid should be forever. It's just the way that it was done, this abrupt, ripping away of all this funding that has supported different countries and different initiatives for years. Like, that's going to result in actual deaths. It's going to result in people suffering. So that was not ideal at all. But we are where we are. So what can we do to kind of build on what is available?
At the recent WHO Africa meeting in Lusaka, Zambia, a number of countries came forward, health ministers and indeed finance ministers, because some were present, to say, we saw the writing on the wall and we got ahead of things. And we had the Minister of Health from Nigeria, Mohamed Ali Pate. We had senior government ministers from other countries as well saying, we are now going to improve and upgrade our domestic resource mobilization. We're now going to start taxing things we never used to tax because it's in our own interest to do so. We're now going to step up because we need to pay for our own health security. What do you make of these moves? How encouraged are you by them?
Yeah, I think it's really encouraging, but it's not easy. So expanding the tax base, that's a lot of structural reforms that are way beyond health, right? And so I think one encouraging country is Ghana, actually. While increasing the tax base and ensuring that those systems are strengthened, they're also moving forward with a national health insurance scheme as well. And they have plans in place, but this is like decades of work that is before them. And I think what encouraged me is that they've set their sights that way. They're not looking for kind of get-rich-quick schemes and things like that. Minister Pate also gave remarks at the Accra summit, and he talked about a lot of different things to increase domestic resource mobilization, showing that this just doesn't happen in a vacuum. So in addition to increasing health insurance and reducing out-of-pocket spending, he talked about the need for creating jobs and, having a workforce that can be more involved in the market, more involved in having purchasing power to drive innovation when it comes to the creation of domestic products of medicines and vaccines and things like that. It's not just saying like we want to increase local manufacturing, whether it be in Africa's CDC or in Nigeria. We need people who will buy those products. And people who buy those products are people who work. And, Africa has the youngest median age out of all the different continents. And a lot of these young people have no work. So if you want to increase the amount of money that a government has to put towards health spending, you have to increase the amount of money that they can raise through taxes. And if you want to increase the amount of money they can raise through taxes, you need to make sure that people have jobs. So I think understanding how all of those things link is really important. And I think that having ministers like Minister Pate that have that vision, the kind of complete vision, is important as well. And I know we're talking about domestic resource mobilization, but he also talked about South-South collaboration and regional partnerships and working with the Caribbean and working with Asia to strengthen our workforce, to have pipelines and pathways established where they can buy African-created products as well. So I think there's a larger picture that's really exciting when it comes to things that are produced in Africa, sold in Africa and across Africa, as well as outside Africa, to really generate some money that can help us with health spending and health coverage as well.
Dr. Ngozi Erondu, Technical Director of GLIDE, thank you very much. That was an engaging, energetic, and hopefully very rewarding conversation.
It's been my pleasure, Henry. It's great to see you again, and thank you for your brilliant questions.
The Threshold is a production of Foreign Policy, made possible in part through funding from the Gates Foundation. This podcast is produced by Laura Rosbrough-Tellem, who also helped create the show. Rob Sachs is our editor, and Indra Dalasakan provided production assistance. I'm your host, Henry Bonsu. Next time on The Threshold, how lenacapavir, the new injectable HIV prevention shot, could transform Uganda and other countries.
The stigma will lessen. If there were lines, I would be the first on the line.
And what else it'll take to end HIV as an epidemic.
1 out of 5 people with HIV still don't know that they have it. The job is not finished.
All that next week.